Hey guys, this is Tammy Dunnett with Nurse Minder, and today we are talking about oxygen saturation. In particular, we're going to talk about how to take the oxygen saturation reading. We're going to talk about what the waveforms actually give us information about, and a little bit about prepping your patient and clinical considerations. And of course, we're going to do all of that right after this. Welcome back. My name is Tammy and this is Nurse Minder, and on this channel we do everything nursing. So if you're new here, consider subscribing below so that you get the next video when it's released. So talking about oxygen saturation, what we typically do is just kind of put this on a person's finger, take a reading, write some numbers, and I don't know if we really give too much thought about what exactly we are measuring. So we're going to talk about that today. So our oxygen saturation, or SpO2 as we call it, is a measurement of oxygenation. And oxygenation is a reflection of our perfusion and ventilation. So our abilities to breathe in and get rid of oxygen, and the abilities for our lung cells to transfer oxygen and carbon dioxide from the blood system into the lungs and from the lungs into the blood system. When using a pulse oximetry to measure oxygen saturation, we're really looking at the hemoglobin that is in the red blood cells and how much of that is bound to oxygen. So each red blood cell has a certain capability to carry a volume of oxygen, and that's what we're measuring, and it's measured in a percentage. So in a normal healthy adult, the normal values are greater than 92%. Now, depending on if you have some other pathology such as COPD, we may actually want it to be lower, 88% or higher, because of what's happening within the lungs. In terms of preparing your patient for an O2 sat reading, education around how it is non-invasive, so there is no pain, it's simply a light pressure on your finger, is important, and that it will simply need to sit there for about 30 seconds while it adjusts and it reads and you get a baseline. Now, in preparing your patient and selecting the place that you will do your O2 monitoring, we often will use the hand and the ring finger to complete that process. Now, we want to make sure that the digits are free from nail polish and that they are warm and they are pink. If they are cold and blue, you're going to get a really low reading, and you want to see if there's a digit that actually is pink. So either hand is fine. In some cases, you might also need to use the toes. Other locations for doing O2 monitoring could be the ear, if you've got the ear ones, and the feet. In infants, we tend to wrap the sensor around their foot pad. Now, when it comes to waveforms, there is a characteristic pattern that we would expect to see in a healthy individual, and that's this first one here, in the normal waveform for a pulse oximeter. And you'll have seen it on my reading as well, that we have this sharp rise up and then kind of almost a hill on the way down. And this is called the dichrotic notch. If you see that present, it is not always there, but we have this rise and fall to baseline, rise and fall to baseline. And this would be considered normal. And with this, we consider a normal stroke volume and peripheral vascular resistance as well. When we have a weak waveform, you may only see a slight rise and fall and a slight rise and a slight fall. This may be due to hypovolemia, that they have a decreased volume in the vasculature, which is causing a decreased stroke volume, and there may be increased peripheral vascular resistance, such as with heart failure. When we have a large bounding waveform, you'll see these really tall structures show up, and they're consistent across. That's not a problem, but they're taller and a little bit more pronounced than usual. So somebody who has a fever, the vasculature has dilated, and we're really pumping that fluid through the heart because we're circulating oxygen. We may have an increased stroke volume, and with that dilation, we have a decrease in peripheral vascular resistance. Other conditions that may be consistent with this pattern would be aortic regurgitation, anemia, and an increasing in intracerebral pressure, ICP. There are some limitations to the use of a pulse oximetry, and that would be nail polish on the fingers. Dark nail polish limits the ability for that red light to shine through. The second would be if the patient is already cold and clammy, there might be perfusion problems. We're going to get an inaccurate reading potentially. And then the third is when they're shivering or there's artifact that can influence the reading. Clinically, there may be some limitations as well. Patients who are anemic have fewer red blood cells. That doesn't mean that their hemoglobin concentration won't actually be greater than 92%, because the hemoglobin that is bound to that red blood cell may in fact be saturated to an efficient level. But our patients may still be symptomatic because they have fewer of them, which means there's less oxygen available to the cells when they arrive. So if you do have a symptomatic patient who is anemic and they have a normal SaO2, then you may still need to use some oxygen. Trauma patients fall into the same category in the sense that if they are bleeding, they are losing blood, but they may have a normal SaO2 reading and still require oxygen if they are in distress. Carbon dioxide is the third clinical consideration I want to talk about at this point. So carbon dioxide has a greater affinity to bind to hemoglobin than oxygen. And in the presence of carbon dioxide, it will still appear as if our patients are satting with oxygen greater than 92%, which can be misleading. If a patient is at all suspected to have carbon dioxide poisoning, you'll want to apply oxygen to improve their oxygenation. And one of the tests they may order in order to definitively identify their oxygen status would be an arterial blood gas. One of the questions I get asked is, how long will it take before I notice a change in my patient's status if I give oxygen and I'm monitoring their SaO2? Well, here's something I like to have my students do, is to put on a SAT probe and hold their breath. In fact, let me do that. Let me grab my SAT probe to see that change. Currently, my oxygen saturation is at 97%. And I'm going to hold my breath for as long as I can. Okay, that's getting pretty long. And you see my oxygen hasn't changed at all. Whew. So it can take a couple minutes before you see a change in your patient's status when you're increasing or decreasing oxygen saturations. So do be sure to check back in on them. That's our lesson on oxygen saturation. So be sure to comment below and let me know how this has helped you. And if you've got some more information, of course, share it, because you know that we are stronger together. And share this with your friends. Let them know that you've watched a really cool video. Like it, thumbs up. And until next time, make it a great day.